Hi everyone, my name is Martijn and welcome back to this special edition of the Sunstar Conversations Pro Series. We're very happy that you're joining us again today, and I hope, of course, that you are all doing very well. Now, what makes today's episode so special? Oh, first of all, it's the theme. So far, we have been discussing oral health challenges across different life stages, and we ended this series last month with a special episode on tips and tricks for caregivers. If you missed the previous editions, go and visit our YouTube channel and subscribe if you haven't done so already. So for today, the theme is celebration because we celebrate two winners of the World Perio Research Awards, an award that highlights research into the link between periodontal disease and general health. And today will be all about the link between periodontal disease and cardiovascular disease. So a very exciting and relevant topic. The second reason why today is a special day is our lineup. Because I'm not hosting on my own this time, supposed to join us today to co-host the conversation is the chairman of the awards selection committee, who is none other than Professor Ken Kornman. Besides many other things, Ken is editor-in-chief of the Journal of Periodontology and retains a research professor appointment at the University of Michigan, USA. However, Ken is experiencing some connectivity issues at the moment, which is also one of the reasons why we started a bit later. But hopefully he can join us at a later stage. But for now, let's dive into today's episode. But before we do, just a little housekeeping. If you're watching and you have any questions, you can ask them in the chat function on YouTube. If you are watching from the Eventbrite page instead, you won't have this option, so you have to click on the Watch on YouTube button on the bottom left corner of the video screen, and this will then take you to YouTube. So let's not wait any longer and introduce the winners to you. And the first place winner of the awards is Professor Jim Beck with his paper titled Periodontal Disease Classifications and Incident Coronary Heart Disease in the Atherosclerosis Risk in Communities study. Jim is distinguished professor at the UNC Adams School of Dentistry and holds a PhD in epidemiology from the University of North Carolina at Chapel Hill. Hello, Jim. Congratulations with your first place. How are you feeling about it?
Hi. Yeah, thank you. It's really been an honor, and there are a lot of people here around our group who's really excited about it and what it may mean. And we've even gotten some local attention from our school, which is kind of unusual. So I think we're all very happy to have received this award.
That sounds great. That sounds promising as well for today. Thanks. I will be back with you in a second. But first, let's introduce the second speaker of today, Dr. Rick Singer. Rick is associate professor at the Department of Oral Science and Translational Research at Nova Southeastern University, also in the USA. And he's the executive director of the Masters of Science program at the College of Dental Medicine. His second place winning paper is titled The Association of Periodontal Disease and Cardiovascular Disease Risk, Results from the Hispanic Community Health Study/Study of Latinos. Hi, Rick. Congratulations to you as well. How do you feel about your second place in this award?
Well, Martin, thank you so much. I feel quite honored, actually. It was quite unexpected and quite a surprise for me, and I really appreciate that. I'd be remiss, of course, if I didn't thank our co-authors and acknowledge them in this effort. It was really a wonderful project to work on, and we're very excited to take part in this award.
Sounds good. Sounds good. Yeah, we have a lot to talk about, I guess. And I would like to start with a question that's actually a question to both of you. You've all had a big impact on the perio community, Ken as well. And coincidentally, you all have history together and you share even several publications. And now this link between cardiovascular disease and periodontal disease brings you together again for today's webinar. What are your personal connections with this topic? What drives you and what excites you? Who would like to start?
I can. As an epidemiologist, of course, I'm interested in studying the determinants of health and disease at a population level. And then as a dentist, of course, I'm interested in my research, most of it concerns oral health behaviors and the associations between oral health and systemic diseases. The fact that cardiovascular disease are the leading cause of death among men and women in the US, accounting for 1 in 4 deaths annually, makes this a very compelling topic. What excites me and drives me is curiosity and the challenge of applying analytic techniques to population data to better understand impactful questions.
Good. Sounds like an interesting mix of clinical work and research interest.
Yes.
I like it. And how about you, Jim?
Well, I've been around a long time, and I was around for some of the original articles that came out of Finland in the late '70s, and so got to know that at least this topic was viable, and those papers. And I then some things happened around our school because I was immediately interested, and Emory University closed their dental school, and Stephen Offenbacher came to University of North Carolina, and we started working together on a variety of things. And when he came, he was already working on a preterm birth paper and study. And so, and personally, you know, I had a friend who was a cardiovascular epidemiologist, and he came and we talked, and he said, you know, we're looking for some other types of potentially new risk factors for heart disease rather than the older ones. And he said, well, we've got a study that's active going on, and thus we was born the dental ERIC study, and the ERIC study was this huge study that has been going on for more than 30 years now, and also has a sister study, which is the Hispanic Community Health Study, which is where Rick's paper came from. So in some ways, we're connected in that way, as in terms of the two studies, major studies, are that way. And what drives me, I think, is that you know, just basically wanting to know how this is all going to turn out. As we learn more, it appears that the role of periodontal disease in systemic health, if there is one, is complex, and I want to be part of figuring it out. And the reason it excites me, I guess, is what I call the chase. It's you know, getting ideas for studies, planning studies, analyzing data, finding new and maybe unexpected relationships, and that's for me, that's just a lot of fun. So we're, you know, always very interested in doing this kind of work.
Yeah, this chase has been going on for several decades, and I think we can all agree that we have made some great progress in this topic and in the understanding of this link. Absolutely. Yeah, going back to the papers that we are discussing today, and starting with you, Jim, if you would have to summarize the implications that your paper has for clinicians or for the research community in one sentence, there's a challenge, what would it be?
Well, I've been thinking about it, and it's a long sentence.
That's
but
okay. You can use a lot of comments.
I think that my feeling about the sentence would be that idea that people may have one or more subtypes of periodontal disease that convey risk for heart disease, and the specific subtypes that do convey that risk may influence the prognosis and the treatment needed to deal with it. I think that pretty well summarizes what that paper is.
Was not so long. Was okay. And I think we can explain more, and we can take a deep dive into what you mean by the sentence when we progress with the discussion. How about you, Rick?
Well, my sentence is almost as long, and it was actually kind of interesting to try to sum it up in one sentence. But I think the summary for our paper would be that we found that in a diverse U.S. Hispanic Latino population, that moderate and severe periodontitis was associated with a significant risk of cardiovascular disease, with marked sex disparity and heterogeneity by Hispanic Latino background group. And I think it was among one of the first explorations of that particular stratification of the findings.
Mm-hmm. Yeah. Again, also, a lot of potential interesting discussion points that we can take from your summary. Yeah, let's take a deeper dive then into the papers and into their findings and implications. And I want to start with you with your winning paper, Jim. You mentioned it already. In order to elucidate certain associations between perio and cardiovascular disease, you classified your periodontitis patients based on the periodontal profile class system, if I'm correct. And this system basically puts patients into buckets, as Ken likes to say, and that's based on specific phenotypes. What was the rationale behind doing this, and what are the characteristics of these specific buckets?
Um, okay, yeah, I think, yes, we did classify our study participants using the periodontal profile class system, which is a new system. And I do remember the first time I heard Ken Kornman refer to those subgroups as buckets. And I like the idea. So I'm going to try and use that term as much as I can today in what I talk about. Um, so to answer your first question, um, we we were not really satisfied with the traditional ways of classifying periodontal disease for several reasons. And one of them is that the traditional reasons usually were based on one or two measures of periodontal disease, and we're not sure that one or two measures were adequately represent this complex disease that we call periodontal disease. Uh, Second, the while traditional measures of periodontal disease have been useful in studying periodontal disease, we had no idea whether um, uh, whether or not they were appropriate for studying the effect of periodontal disease on a systemic disease. And we didn't know if there needed to be other dimensions in order to do that. And I'm not, we're sort of in some ways working that out at this point. Third, these categorizations were done by humans, and there's always tends to be some type of bias, present company accepted, of course. Um, and we wanted to. We've also learned that there are now computer programs available. They're quite good at creating these types of buckets. So we're finding then that the current measures were not at all well associated with genes, and we thought we could do better. So we decided to use an agnostic approach to coming up with a classification. And so we wouldn't be bound by any preconceived notions of what constituted health or disease. So, um, so what we did is we used this latent class analysis, which is basically a computer program. This was being used in medicine for many years, and I think we were one of the first to use it for dentistry. But one of the characteristics of it is it sometimes came up with classifications that were not known before, were not seen before. So we did our own latent class analysis of 7,000 individuals, and it came up with 7 buckets. And so we called these 7 buckets the periodontal profile classes, and later we called them the PPC stages. So to get to the rest of your question, PPC stages are characterized by being mutually exclusive groups of people who are clinically alike and not like any other groups. In fact, people in these buckets that we had here had a greater than 90% probability of being correctly assigned to that particular bucket. And in addition, the people were clinically homogeneous. They were all clinically very much alike. And so we looked at the clinical status of each people in each bucket. We gave them names that would be familiar to most dentists. The names of the buckets were, healthy and incidental disease, mild disease, moderate moderate but disease in the back part of the mouth, and severe disease were the four that were really known. But in addition, it came up with these three extra buckets that represented new groups that were characterized by having more missing teeth than the other four buckets. And we named them mild tooth loss and extensive high gingival inflammation, and moderate tooth loss and reduced periodontium, and then severe tooth loss. So that's how it all came about and why we did it. So that's, I guess you've heard enough from me now on that.
I think it's sufficiently answers the question, and yeah, it greatly summarizes how these buckets work. And I think that's a good start to think to also capture your thought process that you put down in the paper. I see in the background that we have another guest queuing up. Maybe we can put him on screen. There he is. And Professor Kornman, welcome.
Thank you.
Yeah, we noticed that you had some connectivity issues, so we apologize if that we already started without you. Yeah, but you're still very welcome, of course, nonetheless. I already introduced you, but part of that introduction was that I would like to ask you if you could maybe explain in a few words why these World Perio Research Awards are so important and so impactful and meaningful.
Yes, I first of all, I'm very pleased to be part of this. And I've been involved for several years, and I'm just amazed each year in terms of when we take a look at the papers that have been published across a broad range of journals. And that is absolutely astounding from my perspective. So the great thing about these awards is that with the journals, with Sunstar, with a variety of institutions that are involved, because there are many papers that have been submitted each time we review these, and it's very almost anonymous in terms of what we're doing to make sure that we get as close as possible to a really complete but new look at the structure that's in the paper, that the size of the group that's been studied is substantial, and most importantly, that the methodology is very, very strong. So from my perspective, the exciting thing about the two papers that are being discussed here today is they're really fantastic. First of all, I'm very biased about work relative to cardiovascular disease, and both of these groups and the studies involved and the databases are fantastic.
Mm-hmm.
So that's really important in terms of drawing attention broadly across disciplines and making sure that this work does get attention, because it's certainly well deserved, and I do have some perspective on how much work goes into these studies, and it is remarkable. So
Yeah.
I was pleased to rejoin and hear some of Jim's comments, and actually I'm very interested in both of these studies, and the main issue, which I heard Jim refer to with their periodontal groups, that they used some totally anonymous clustering, or however you would like to classify them. And the beauty of it is I'm seeing the same thing throughout cardiovascular disease in terms of the new evidence that's coming out, much of which is not well studied and much of which has not been focused on in recent years. And there are a couple of examples. One is the Canto study, which is fascinating because a key parameter in periodontal disease, which is one of the cytokines in particular, interleukin 1 beta, and Cantos basically used a very powerful drug to block IL-1 beta and showed they could reduce second heart attacks pretty substantially. I know the investigators well, and I thought I knew the study well, but I was shocked the second day when, in spite of my being familiar with the study, I wasn't at all expecting the second day announcement, which was not cardiovascular disease, but it was in fact a 70% reduction in incident lung cancer.
Mhm.
So they were put together a study. Over 7,000 people followed longitudinally. With these were people who had prior cardiovascular events, and they blocked this single cytokine and got a significant outcome. But lo and behold, the next day they reported with the same group that was in the cardiovascular entry into the study, they saw a phenomenal reduction in incident lung cancer. And that was just another example of the fact that we're putting together multiple pieces for these complex diseases that interact substantially with each other. And the periodontal work, which these two groups have done, is really well focused. And as Jim pointed out, although we know we have to go broader, it's not totally clear to us how broad we should go. And so the different ways we're selecting parameters or drawing broadly on them is really substantial. Now, may make one more comment, Martin. So I'm fascinated by the studies that we're talking about here. And one of the factors that's become very clear in terms of cardiovascular disease is that some of the parameters that are being used to mark a high level of one parameter or another have become very important for us looking at periodontal disease. For example, the level of LDL cholesterol, which for many years had a kind of a quote predictable threshold. Now, in fact, the latest studies with some new drugs indicate that we actually want that threshold to be below 70 milligrams per deciliter in order to count LDL cholesterol as still being of some threat to a variety of factors that we would be concerned about, and factors that we would be concerned about in periodontal disease. And same thing with one of my favorites, which is Paul Ridker's high sensitivity C-reactive protein. And as Rick points out in his work, for years we had identified key cutoff points for being of low CRP value or being some moderate value or being greater than 3 milligrams per liter, which Rick uses, as we did for years, in terms of a major risk if we see that level of inflammation. But now it's well documented in the last work by Ritker and Peter Libby, is that they go above 2 milligrams per liter now as being a threshold that's consistent with second MIs, second events, and cardiovascular deaths. So those were aspects that, in spite of lots of evidence to support those threshold levels, they're starting to see more sensitive factors that affect lung cancer and most likely periodontal disease. And so there are real opportunities for us to interconnect the periodontal part and various other diseases that cardiovascular is certainly a primary one.
I like that most of the side steps that you just discussed basically all come down to some disturbances in the inflammatory response. There's, and we will discuss this later when we talk about, what is the biology behind this link between cardiovascular disease and periodontal disease. But you mentioned it also has links to cancer and lipids and metabolism. Lipid metabolism is also involved, and it all sort of comes down to this sort of disturbance of the immune system. And I think that will be one of the topics that we will discuss later in this webinar when we talk about, how can we biologically explain this perio link with cardiovascular disease. Now, when you joined, before you joined, Ken, we were just going over to Rick to ask him some questions about his paper, and that's what I would like to continue to do now. When we go into your paper in more detail, Rick, because you also looked at the association between perio and cardiovascular disease in a specific subgroup of perio patients, namely those with a Latino, especially Hispanic background. What distinguishes this population, and how does this cultural or ethnic background, as you may call it, influence the relationship between perio and cardiovascular disease?
That's a very interesting question, and thank you for that. Well, unlike previous national studies, the Hispanic Community Health Study of Latinos is among the first with a complex population sampling design that recognizes the cultural heterogeneity that exists in the U.S. Hispanic Latino population. As such, the study's unique design permitted us to examine how the association between periodontal disease and cardiovascular disease risk varied by Hispanic Latino background groups. Now, the outcome measure that we used to assess cardiovascular disease risk was the Framingham 10-year general cardiovascular disease risk score, which predicts the probability of having one of a constellation of 9 different cardiovascular outcomes in the next 10 years. So the greatest cardiovascular disease risks for both men and women we found occurred between the ages of 60 and 69. And for this age group, we found that Dominican men and women in particular each exhibited the largest Framingham risk score, 15% and 40% respectively. And given the fact that our analyses controlled for many of the well-known putative causes of cardiovascular disease, we can consider this an independent risk on top of pre-existing risk, which is quite striking. The smallest risk scores we found for those aged in that same group, at 60 to 69, occurred for South American women at 6% and cultural and Central American men at 23%. In this age category, the risk differences between the highest and the lowest risk categories among the Hispanic Latino background groups were a 9% risk difference for women and a 17% risk difference for men. So the stratification by background groups gave us information that before this we had not known, and it's actually very interesting. It begs the question, why are the cultural differences really, or what are underlying the cultural differences
Exactly.
on nativity, let's say, that lead to such striking differences in long-term risk?
Yeah. Is there speculation on what those differences, what could be the causes of those differences? Is it genetics? Is it purely cultural?
Across South America, for example, there are hugely different phenotypic differences among the various countries and genotypic differences as well.
Mm-hmm.
And I assume what goes hand in hand with that are differences in diet and physical activity patterns and so forth. And I'm sure all of this in a multifactorial way contributes to the differences that we found.
Mm-hmm. Yeah. Interesting, very interesting. So going back to the paper from Jim and his findings, we've been talking about buckets, Ken, the word that you introduced into this world, and we've been using since then. Jim, you did find associations between periodontal disease and cardiovascular disease in some buckets, but not in all. Maybe could you speculate or explain what were the main characteristics of those buckets that did show an association? And could you maybe explain or speculate on those specific associations from also a biological point of view? And I'm sure here's also Ken's insights could be very valuable.
Oh, good. Thank you. Yes, some buckets were associated with coronary heart disease and not others. And I want to make the comment that, in fact, this is what we usually find in all of our studies, that I can't remember a time when all buckets were associated with any outcome of interest that we had. And so our feeling right now is it's not periodontal disease, it's what subgroups of periodontal disease are associated with the condition. But to be a little more specific on this particular paper, here we have 4 different outcomes of interest, and one was incident coronary heart disease, the other was incident myocardial infarction, or MI, the other was the incident fatal CHD, and the fourth was incident congestive heart failure. And right from the beginning, we found that none of the buckets were associated with congestive heart failure. And only two really of our buckets were associated with cardiovascular disease or coronary heart disease. Our severe tooth loss bucket was associated with incident coronary heart disease and incident MI. And only our stage 5, which consists of mild tooth loss and extensive gingival inflammation bucket, was significantly associated with fatal coronary heart disease. And what we found, and it's very interesting to me, for example, that the bucket related to fatal coronary heart disease was mostly characterized by having more teeth that were been lost and extensive gingival inflammation. Previously, we found this bucket has been associated with several systemic diseases and other biomarkers. And of course, it appears that one underlying association is inflammation. And the fact is that Eric, here we did this longitudinally, may indicate that this bucket carries some excess risk for fatal CHD. But I should also mention that this risk was adjusted for all kinds of variables, cholesterol, HDL, all the things you might expect to be, as well as educational levels and smoking and body mass and things. So, but the thing is that gingival inflammation is reversible and can be prevented by good oral hygiene. So treatment may have some effect on the incidence of fatal CHD in this instance. We don't know. Um, and But the severe tooth loss group, and also the other thing is that it seems to me that for us and what we're seeing is high extensive gingival inflammation is very important, but yet it seems to be neglected by clinicians. It tends to be once someone has periodontitis, they don't even look at it. And I think maybe poor old gingival inflammation may need some more attention in the future. But the severe tooth loss bucket showed elevated risk for both incident CHD and incident MI. But this group, on average, have only 8 teeth left in their mouths.
Mm-hmm.
But they have a whole lot of disease in those 8 teeth. So it's obvious that doing treatment for this group will help their oral status. But it's really kind of, we're not sure that just dealing with 8 teeth will reduce enough oral inflammation to be seen systemically. But that's the kind of information you can get from having these different separate buckets that are different. For the biology, for example, we find that our severe disease bucket has high levels of microbial counts involving red and orange pathogens, and also high levels of antibodies that apparently have been around a long time. So they may not be good working antibodies.
Mm-hmm.
And the severe tooth loss bucket also has high levels of microorganisms and very low antibodies, indicating that these individuals may not make enough antibodies to reduce these organisms. So what we're seeing actually is the different buckets have distinct microbial patterns. And I think that with that, in the future, we may be able to help us in designing perhaps treatments. That's where I would go from now. So thanks.
Your finding on the tooth loss is for me very intriguing, and it also raises a question to me now. Is it the fact that people have fewer teeth that is predictive of a cardiovascular disease event, or is it the long-term disease process that caused this tooth loss? Is there a way to make a distinction between the two? I can assume both have a role. I mean, the whole inflammatory processes that causes tooth loss over many years might increase, I think, the risk of cardiovascular disease, but also the fact that you have fewer teeth impairs your functioning in so many ways: eating, swallowing, your social interaction, quality of life, all these kind of things. Is there a role for both, you think? The others cannot.
And actually, people who've lost all their teeth consistently in our data have worse health than any of the others. So there's a lot of behavior going on in there, the culture, etc.
Martin, may I make a comment relative to the tooth loss? It's very important for multiple reasons. If we go back to the late 1970s, there was a study from just a couple of good periodontists in their practice. The new approaches to how periodontal disease should be treated, with work going on at Michigan and work going on in Gothenburg. Everybody became pretty much consistent in terms of how we treated the disease. But a pair of periodontists, Hirschfeld and Wasserman, in the late 70s, published on about 600 of their cases that they had treated the same way and monitored. And the most impressive thing to me is pretty much what Jim just talked about in terms of missing teeth. What Hirschfeld and Wasserman reported is that right at about 80% of their cases lost on the average 0.5 teeth over more than a 10-year period of time that they were monitored. I tell you, to any chronic disease and any clinician that treats chronic diseases, that's a pretty remarkable outcome of success. But what they also reported is about 20% of their patients treated by the same periodontist, maintained the same way, actually lost on the average between 5 to 14 teeth. Now that is equally incredible by the fact that the cases did not respond to the same treatment by the same clinicians and maintain the same way. I'll tell you, all the people that I was surrounded by at that time quickly spoke up when they saw the papers and said, oh, they just weren't maintaining the cases properly. Yeah. That wasn't the case at all. It was really more back to Jim's point. There was something different. Today, they would call it hyperinflammatory or hyper something like that, due to a variety of factors. And it may be an inflammatory component, may be a bone component, a variety of things. But now we see these differences pretty substantially. And with the new classification of periodontal disease proposed in recent years, one of the factors that we built into that classification was the loss of teeth. Yeah. Because prior to that, we just wouldn't count the missing teeth who came in with periodontal disease. And it's unfortunate because it would, if we discounted the number of teeth that were lost, potentially due to periodontal disease, we might underestimate completely the severity of the periodontal disease. The other thing I was fascinated by in Rick's study is the Dominican background, and the fact that it was so different, really. One of the other factors that's become very important in cardiovascular disease is a different lipid that has been known for about 30-something years, but nobody was sure what it did. And this is called lipoprotein A, or LP little a in parentheses. And a group primarily out of University of California at San Diego have been working on that for years. And they borrowed some samples from a study we did at the Mayo Clinic, and they concluded, to everyone's surprise, is that the LP little a actually had a stronger effect in terms of inflammation and a couple of other mechanisms than LDL cholesterol did. And relative to the Dominican findings, the LP little a is almost 90%. The level of it is almost 90% determined by your mother and father. It's almost as pure from a genetic standpoint as you can get. Statins don't lower it, diet doesn't change it, exercise doesn't change it, and there's very little that will change it. So Joe Whitston, who took some of our samples from the Mayo Clinic and published it in New England Journal, and I had the pleasure of being part of that. And basically, Joe then went down the street from his office to a company called ISIS at the time and convinced them to develop an antisense drug that would reduce Lp(a) substantially. And they've been very successful with it. There are now 3 antisense drugs that are identical that are in clinical trials. Novartis is in a phase 3 study with the antisense drug. And we're all looking to see if, in fact, by lowering Lp(a), they make a dramatic difference without affecting LDL cholesterol.
Right. Yeah.
They make a substantial difference, and all of it, to a great extent, comes from a lot of geographic populations that have been isolated or very limited in terms of the parentage. So I think the examples that Rick has described, there's a lot of information there that we're just scratching the surface of, and this new lipoprotein A is a very good example.
Mhm.
Well, you've just presented a great framework for future studies.
Yes.
You really take a look at it at that level, right? These
Yes.
right.
And I can tell you that, as it turns out, there have now been 3 studies done on Lp(a), and what we showed in the Mayo study was that we have a set of genetic factors that determined whether elevated Lp(a) made a difference in terms of second events. And a couple years ago, we published a second study out of Greece that showed exactly the same things. And it turns out being a pro-inflammatory genetic pattern, some of the ones we're looking at with Jim right now and some other diseases. And it's clearly an effect interacting with the Lp(a). So exciting stuff in the next few years.
It is. And it's exciting to be able to discuss this today. I mean, it's really, really interesting. I wanted to stay with your paper, Rick, as a final discussion point on your paper, because you demonstrated that cultural and ethnical background was not the only factor that influenced the link between perio and cardiovascular disease. There may be also a role for gender. I mean, it's more or less common knowledge that men have a higher risk for cardiovascular disease compared to women. What was the role of gender in your study?
Oh, well, thank you for that. Yes, there was a very interesting role that we observed for gender in our study. We found that the overall combined prevalence of moderate and high cardiovascular disease risk among men was 54%, which was more than double the risk among women at 26%. And when we look at the cardiovascular disease risk by periodontal status, we found that for women and men with moderate periodontal disease, the combined prevalence of moderate and high cardiovascular disease risk was 35% and 62% respectively. And for those men and women with severe periodontal disease, the combined risk was 44% and 85% respectively.
Wow.
So it's quite an impact based on the sexual disparity that exists in the prevalence of risk. But additionally, the prevalence of cardiovascular disease outcomes varied markedly by many of the population characteristics that we observed in our study as well. So for example, for both men and women, the unadjusted prevalence of high cardiovascular disease risk was highest among those that were the oldest, the least educated, and with the lowest incomes. Moreover, this high risk was also observed among those who were foreign born, preferred to speak Spanish, had the longest US residency, were diabetic and current smokers. So for me, the finding among those findings that I was most drawn to was that finding that related to the longest U.S. residency. In other words, relative to acculturation, as our participants became more Americanized, their cardiovascular disease risk increased. So it's very interesting. You know, what is it about that?
I'm not emigrating. I'm not immigrating to That is really interesting. I mean, really interesting. Do you see these disparities between these different populations also in non? Do you know, or is it something that? Do you know if
I'm
these
sorry,
disparities?
Sorry.
Maybe there's some delay in the connection.
Yeah.
Do you see these disparities between these different profiles, for example, gender or immigrants versus non-immigrants, also in non-Hispanic people, or is it really something that is specific for the Hispanic population?
Well, we know. I mean, as you said early on, there's basically the other characteristics that I described are many of the commonly known and commonly identified risk factors for cardiovascular disease, smoking and so forth, right? And low income and low education and age. So we know that it cuts across cultural differences in all segments of the population.
Yeah.
What was sort of interesting to me, we did a study unrelated to oral health that looked at occupational exposures and obesity. And we also found the relationship with acculturation with those in the US for the longest period of time had the highest risk of developing obesity. So these risk factors seem to go hand in hand with acculturation.
Mm-hmm. Yep. Interesting. Very interesting. Yeah. Love that answer. Okay. I think we can continue to a your discussion, because with everything that we discussed now, I have a question for you both. Because when I interpret both your findings correctly, we can conclude that apparently this link between cardiovascular disease and periodontal disease is not so straightforward as we might think. There seem to be several risk patterns by which you can stratify or classify certain perio patients, buckets, if you like. What does that mean for the treatment of periodontal disease? Thinking from the mind of a clinician, do we need to approach certain groups of patients differently? Sometimes, we sometimes refer to as precision medicine. And how do we do that? Who would like to have a go?
I guess I can go. Yeah. What about treatment? Something that sometimes keeps me awake at night. I wanted to mention that in addition to incident CHD, these buckets appear to be related to excess risk for incident stroke and diabetes and peripheral artery disease and cognitive decline and Alzheimer's disease. And one of the things that really bothers me right now is that we really, don't know whether our treatments are for all of these buckets. And because the buckets are all different, and we don't know what the appropriate treatments are for these buckets. And I think it's one of the pieces of information that we really need to have. But one of the reasons I like having these buckets is that, again, we think it's one of the types of classifications that enables this precision medicine or precision dentistry. And just for brief explanation, what I'm talking about is, precision dentistry is a whole lot like personalized dentistry, which we've been talking about for a long time. It means that, periodontal disease in one person isn't necessarily the same disease that someone else has. For example, for me, my genes from my parents and the environment that I live in can influence my periodontal health and my symptoms that I have, and even how well the treatments may work for me. And but the way precision dentistry differs is that while it emphasizes groups of people. It thinks the idea is that our system can't to cope with having a different type of treatment for every individual. And so the idea is it's about identifying groups of people who are clinically and biologically similar so that the same treatment will work for all the people in that group. And I think that's one of the things that I think is going to be very important to organize for the future. And, a lot of parts of medicine are doing that now.
Jim, one of the interesting points that you brought up was parallel the note that I made in preparation for today. And that is the idea that when you were talking about the different buckets and the potential pathogens associated with each of those buckets, it really points out that in both of our papers, we're trying to connect phenotypic expressions of disease with other disease outcomes.
Mm-hmm.
And that perhaps if we could identify unique bacterial profiles associated with each of the classifications, whichever classification of disease system that we're using, and maybe routine dentistry in the future will involve taking DNA analysis of the pathogens that are either in lesions or just in general, and identifying which type of bacterial profile associates with a class of disease status or health status, and then that defines an approach to treatment.
Absolutely. Yeah. I mean, I forgot to mention that, of all these different conditions that we may be associated with, the different buckets are associated with different conditions.
Right.
So it's all very specific and complex. So.
Mm-hmm.
Yeah.
One of the points that Rick just made and that Jim had alluded to earlier really has to do with the fact that we will see a good response clinically with the periodontal treatment, but that doesn't at all mean that we've altered the systemic impact of that treatment. And as we put into the new classification, almost as a blank space, but there are companies that have already developed biomarkers. They're available commercially, better used in some countries than the US, but the data is actually pretty good. And you can start to get some biomarkers that give you a good sense of what factors you're influencing in some of the groups that Jim looks at. The biomarker patterns may well be very different in those patients. And at the same time, we may or may not be influencing blood parameters systemically for those patients. So, it's appropriate that we start doing what Jim and Rick are doing broadly for the benefit of all of us to better understand what's going on here, and to most importantly acknowledge that the periodontal disease has implications in multiple parts of the body, multiple mechanisms. And although I started my career as a microbiologist, it didn't take me long to realize that I had to look at some other things besides the bacteria. And most importantly, to me, was the realization that there was an interaction with the bacteria and the host parameters that were pulled into the periodontal space. And so we activated other mononuclear cells and a variety of different antibodies and various things. And in fact, Jim, you may not remember it, but I remember a paper I asked you and Steve to write a commentary when the AAP had reached 100 years. We invited individuals to write commentaries, and you and Steve wrote a wonderful short commentary. As always with Steve, I enjoyed constraining how much he wrote. I could always get him into a really focused point. And paper in 2014 was that they were looking exactly at what I just mentioned, which were the bacteria interacting with different cell types and activating them in different ways, and broadened our horizon in terms of how we should think about periodontal disease.
I definitely remember that, and thanks for bringing that memory up. It was a good one. So,
it was a good paper.
Yeah.
Gentlemen, I realize you probably haven't noticed, but we've already exceeded the 1 hour mark. And this webinar was supposed to go on for 1 hour. So although I like to coincidentally break some rules, I think we need to wrap it up for now. I saw that there is a question from the audience, but before we go to that, I do want to ask you one more thing, and that is about the future. Do you have future plans in terms of research when it comes to the link between perio and cardiovascular disease? Just your comment, if you would like.
Well, for me, I think it's recognizing that one of the primary gaps that still exists in the literature is supporting the case for causation. And I think that's the next step that would really tighten up our understanding of the nature of the relationship. In my mind, one of the primary questions is, what is the magnitude of the impact of periodontal disease on cardiovascular disease outcomes or risks? And is it playing just an incident, a side role, or is it a primary etiologic factor? And we haven't answered that question yet. So in my own area of interest, one of the things I've been interested in doing is borrowing a statistical technique from the field of econometrics, combined with Mendelian genetics that support using instrumental variables that would permit using the types of cross-sectional data that already exist to make a case for causation. So that's it's exciting to me for two reasons. One, to begin building evidence towards causation, and two, because I love analysis. It's an interesting and analytic technique. Yeah. But something that I'm interested in pursuing at the moment. Yeah.
Already looking forward to that future publication. And what about you, Jim?
Just because of time. Basically, we're going ahead, still looking at the genetics of these different subgroups, these different buckets related to it, and also the thing we really would like to work is what I've just been complaining about, which is I'd like to see if we can do some progress on treatment for how these different groups respond to treatment would be the clinical aspects we'd like to explore.
A lot to do. There still is a lot to do. Interesting, very interesting. And Ken, we shouldn't forget you. Do you have anything ongoing or planned for the future?
Yes, actually, it's incredibly connected to what these two guys just talked about. We have a paper that's either just coming out, it's being presented at the AAP annual meeting that's coming up in a few days, and one of the presenters was key on this paper. But basically, what we're doing is we're using some oncology methodology that basically is taking a look at peri-implantitis problems, and can we look at the bacteria that are there, the cells that come in, and as either Rick or Jim mentioned, Some of them will produce good antibodies, and some will produce lower level antibodies. And so we've adopted some of the technology that is currently being used in oncology to characterize the cell types that are activated by some of the cancer-causing mutations. And so I think that what Jim and Rick are talking about are really at the heart of where we have to go with all of this.
Amazing. Yeah, so it sounds like two well-deserved winners.
Yeah, and one thing I should mention for Rick is actually I started my undergraduate career in econometrics. And the person who was my mentor was Juanita Krebs, who was Secretary of Commerce under one of the presidents. And years later, someone asked me how I got into dentistry. And I said, believe it or not, Juanita Krebs called me into her office one day, my junior year, and said, why is it you're majoring in economics and you're taking all of these graduate level science courses, and quite frankly, you're pretty good at it, and quite frankly, you're a miserable econometrics guy. And she was right. And so, and she actually, they went and interviewed her, and she said, I don't believe any of it. I don't remember it, but I'm glad I at least nudged him to get to find a career somewhere.
Thanks for sharing that. That's great.
It seems there's also already a partnering up happening here, and
right.
For your future stuff, Rick. That sounds. You see, you never know from which area the help comes
That's
from.
correct.
Amazing. All right. I think that wraps up our discussion, at least for today. I did understand there is one question, not necessarily related to cardio, but maybe it's nice to throw it in anyway, because we have some clinicians here. It's more a clinical question. If you have two unrelated teeth in quadrant 2 and quadrant 3 that have bone loss and gingival pocket of 5 millimeters, but one of the two teeth does not bleed, can you diagnose it as local periodontitis? That's a very detailed question. Do we have an answer?
Well, I'm happy to give you my views on it. And basically, we have to look at what's going on in the area in terms of the microbiome and what else is going on in terms of how the patient is cleaning, especially interproximally, and how we as professionals are helping to reduce the microbial load and what else goes into that. We pay a lot of attention for good reasons to the bleeding, and more, I think the types of groupings that Jim is putting together gives us some insights as to some of the things we should think about in terms of the differences.
Does anyone else want to comment, or shall we call it a day? I see Jim nod. Okay, then I hope that answers to your question sufficiently. And for everyone else who had a question that you didn't put in the YouTube chat, or it wasn't answered, we will try to answer those afterwards as soon as possible. In any case, being 10 minutes overdue, I think it's time to thank the speakers of today. And I want to start with you, Ken. Thanks so much for hosting with us today. Your insights and your contribution, not only today, but to the periomedicine field in general, are really invaluable. So thanks a lot for joining us and hosting with us today.
Thank you.
Thanks.
And then, of course, to the two winners. Jim, congratulations again on your fantastic paper. And it was absolutely a pleasure talking to you and hearing your insights.
Yeah, I enjoyed it too, and I learned a lot, so that's great.
Wonderful. I think everyone did. And for you as well, Rick, the insights from your paper have been truly meaningful as well. So thanks so much.
Well, thanks so much, and I appreciate that. Now I have a resource to talk about econometrics with. So it's
Right.
Everybody wins.
That's right. That's great. And thank you, Jim. Appreciate it.
And as always, of course, also a big thank you to everyone who has joined us today to watch. Don't forget to subscribe to our channel to stay up to date. You can find us also on Twitter, Facebook, and Instagram at Sunstar Global. Or you can visit our website, sunstar.com, sunstarfoundation.org, or sunstargum.com. We will be back in 2 weeks on the 18th of November, that's a Thursday, with another episode dedicated to the World Perio Research Award again, but this time on the interaction between the oral microbiome and cancer. So again, a very, very interesting topic. As always, keep an eye out on this channel. Thank you again and catch you all next time. Goodbye all.